All right, hello everybody. Can you hear me and see me? No, it's kind of dark. It's very gray here. Okay, so let's go to the next chapter. We can get that put up on the screen. Well, actually, I should probably go back there. Any questions while they're doing that? Okay, as we have this dead silence. I'm still unsure as to where to draw the line with depression versus grief. What you have to understand is focus on the functioning, severity of the symptoms, and stop focusing on the time. So forget time. If the functioning, here, let's go to the whiteboard. Oh, there it is. It's staring at me. I'm like in slow motion today. So when you've got grief versus depression, if the patient is functioning, then time is important. If the patient is not functioning, then time not important. Does that make sense to everybody? Okay, so focus on, this is what I want you to focus on and not this. What's the difference between loose association and tangential? Flight of ideas versus tangential? They're different things. Tangential is, I'm talking about a topic and I have to reach the end of the topic. I start telling you the story, I get off the topic, and I never make it to the end. That's tangential. So pretend I'm telling you the story about Little Red Riding Hood. So Little Red Riding Hood is going to visit her grandmother. You know, when I'm done teaching, I thought I was going to go out, but I don't think I want to go out because I'll probably be tired. I think I'm going to go out tomorrow morning. What are you doing? So I left you like, so what happened to Little Red Riding Hood? I never made it back. That's tangential. Flight of ideas versus looseness of associations is, I'm going from one topic to another topic to another topic to another topic. There's going to be something connecting me from this topic to this one, from this topic to this one. If there's nothing there, that's loose. So I'm just picking topics at random which are not connected at all. What do you think of my hairband? I really like hairbands, and I think black is probably the best hairband. You know, I put batteries in my mouse earlier today because it was dying. I love my new battery. I love my new eyeglass case. What was that? Was there anything connecting? I went from this to this to this where there's no connection. Now, had I said, I like this hairband, I especially like the black ones. What do you think of my black case? I like the black case with the pink letters. Kids love pink. My little kid's room is in pink, and pink and purple are her favorite colors. I've been writing in purple a lot. What do you think about that? There it's connected. That's flight of ideas. Do those two make sense to you? They will never, ever, ever, they will never give you a paragraph and then say, is that flight of ideas or is that loose associations? That is not going to happen. What they will do is that they'll give you a paragraph and put in there, he has loose associations or she has flight of ideas. That's what they'll do. But they're not give you a topic and say, what is it? That's not how it's going to work. So does that make sense? Does that make you feel a little bit better? Alrighty. Let's go back to the notes. Okay. Schizophrenia, what do you think? High yield or low yield? High yield, exactly. High yield it is. Let me get some color in here. Let's make it thicker. Okay. So there's good news for you here, because they've actually changed a lot of the as far as the types of schizophrenia. So let's begin with the basics. What in the world is schizophrenia? And schizophrenia, excuse me, is a thought disorder. And a thought disorder is, in my personal opinion, is probably one of the worst disorders you can have, because it affects this. It affects your thinking. It affects how you relate to reality. It affects your judgment. It affects how you relate to other people. And for you to have the diagnoses, let me take this lampshade off. I think it might be better. There. Is that brighter? I think that might be brighter for you. Okay. So for you to have the diagnosis of schizophrenia, what's essential is that you've got to have at least 6 months of duration. Now, for the test, remember, for the test, this is not going to be important, but in the real world, it's very important. For you to have the diagnosis of the schizophrenia, as is true for anything in psychiatry, what has to happen is that it has to affect your level of functioning. Because of the illness, you're not functioning. Because of the illness, you're not going to work. Because of the illness, you think you've been possessed by the, I don't know, gecko monster, whatever it is. So what causes schizophrenia? Nobody knows. They believe that it's associated with increased levels of dopamine and problems with serotonin as well. So that's why the newer drugs, of course, work on dopamine as well as serotonin. The old drugs worked only on serotonin. The newer drugs work both on serotonin as well as dopamine. We know that schizophrenia is genetic. So when you look at the rates, the greater the genetic tie, the more likely that you will have schizophrenia. We know that it occurs 1% across the world. We know that it has equal incidence in men and women, except men tend to get it when they're younger. So the younger you are, the greater the risk, the worse the prognosis. The older you are, the better the prognosis. So men tend to get it between the ages of 15 to 25. Women tend to get it between the ages of 25 and 35. So therefore, because men get it when they're younger, they usually they tend to do worse. Schizophrenia has been associated with low socioeconomic status. Let's go to the whiteboard for this. And there's two theories for this. One is the downward drift, and you don't need to know these for step 2, but I'm just going to tell you anyway. So you are in the high socioeconomic status, right? You develop schizophrenia, so what happens is that you drift downward to the low socioeconomic status. This is called the downward drift theory. The other theory is the social causation theory. So you are in the low socioeconomic status, all the stresses that are going on there, you develop schizophrenia. Where did you go? You didn't go anywhere. You stayed in the low. And that's why they think that you find more schizophrenia among the lower socioeconomic status. So the prevalence rates, it affects 1% all over the world. Let me get some color here. Give me 1 second. If you've got one parent, it's 12%, but two parents, it's 40%. If you're a monozygotic twin and you have schizophrenia, then you've got the other twin has a 47%, but if you're a dizygotic twin, the other twin has a 12%. So you see, the more genetic, the more involved, then the greater the risk. Someone has schizophrenia, well, you're going to have hallucinations, remember. You can have either auditory or visual, but typically you're going to have more auditory. It's about 2/3 audio and about 1/3 visual. You're going to have delusions, and they tend to be weird. They tend to be strange. They don't have to be, but they usually are. You can have disorganized speech or behavior. You can have catatonic symptoms. You can have negative symptoms. So what were the negative symptoms? Things like flat affect. Things like poor grooming, so your grooming is affected. Things like social withdrawal. These were all negative symptoms. So patients, what they do is that they don't interact with you. They don't have any emotions on their face. They don't take care of themselves. They don't bathe. They don't relate to other people. They isolate. And of course, you need to have that dysfunction. So are there some brain imaging findings in patients who have schizophrenia? Yeah, it doesn't mean that I'm going to go order CTs or MRIs on all of these patients. So what you typically find is that if you do a CT or an MRI, what you will find is enlarged ventricles. Let me try to draw this for you. I'm not the greatest drawer, but I will give it a whirl here. So what do we have? So you've got, I know it looks like an Angry Bird or one of those lucha libre. It's not. Remember, I'm not an artist. So what they could give you is twins, right? So these are both monozygotic twins, meaning their brains should be identical. But what do we find here? This is the non-schizophrenic twin, and this is the schizophrenic twin. So what do we find? The schizophrenic twin has enlarged ventricles, or he's an Angry Bird. Well, I don't know how to draw. So the greater the ventricular enlargement, the worse the prognosis, the more likely that the patient will have negative symptoms. Another thing that you typically find when you do PET scans, and how do we do PET scans? Remember, you inject something and it's going to be radioactive. It's going to attach itself to the receptors. So the more color you find, that means that that area of the brain is active. When there's less color, then you see that area of the brain as less active. So if I were to give you a PET scan, again, looking at those schizophrenics, and this is not what PET scans look, but what you'll see is, let me see, usually reds and greens and all kinds of bright colors. So in the normal, you'll see like a lot of redness here, right? A lot of pickup, whereas in the schizophrenic, you might see something like that. So what does that tell you? It tells you that schizophrenics tend to have problems in the frontal or the prefrontal areas. So what do we know about the frontal areas of the brain? Tell me its functioning. Behavior, personality, abstract thinking, executive functioning, and are those things potentially affected in the schizophrenics? Yes. So that's why schizophrenics can have areas of hypodensities in the prefrontal frontal cortex. Okay, let's move on to the slides. Now, as far as IQ testing, the sicker you become, just because you have schizophrenia doesn't mean that your IQ is going to go down. But the worst the symptoms, if you believe that, you know, if you're totally psychotic, then you know, of course, that your IQ is going to be affected. So there's not much. What do we do to treat these patients? We want to make sure they're safe. We might need to hospitalize them, and we're going to give them antipsychotic medications. But I will go over all the treatment questions in excruciating detail on Tuesday. So if you could hold on, that would be great. The biggest differential for schizophrenia is going to be drugs. Why? Because cocaine can mimic schizophrenia. Remember, cocaine raises dopamine. So cocaine can make you paranoid, cocaine can make you hallucinate. So if someone comes in and they're psychotic, then you order a urine drug screen. Cocaine stays in the system a couple of days, a few days. So if it tests positive for cocaine, then it might be substances and not necessarily schizophrenia. All right. So there were 5 types of schizophrenia. Schizophrenia paranoid, disorganized, catatonic, residual, and undifferentiated. When converted to DSM-5, all the types of schizophrenia were removed. They're not how we make the diagnoses anymore. My concern is, I don't know how cleaned up your exam is. So I'd rather go over it, tell you that it doesn't exist in DSM-5. I want you to understand it, because if it's not there, fabulous. You don't have to worry. But if it is, I would hate to have you stuck trying to answer these questions. So we'll go over them quickly. What I do to think about the different types is that I like to put these types in a theme. Something about the question is a theme. Think of the theme, and then you can link it to the type of schizophrenia. So let's start with the first one. A 42-year-old man is brought to the emergency department by his parents after they found him covering the windows with aluminum foil because they were after his ideas. When asked who they are, he looks up at the sky and points at a faraway planet. What's the theme here? The theme is persecution, right? So anything involving persecution or grandiosity is the paranoid type. The FBI is after me. The KGB is after me. The CIA is after me. They have a chip in my brain. They're reading my thoughts. They're controlling my mind. Those are the types of things that you find in the paranoid type. Typically, because these patients, it happens when they're older, you know that their prognosis is going to be better. And this one was the most common of all the schizophrenics. So I would tell students before, if you're stuck in a question, pick the paranoid. But now paranoid doesn't exist. So just in case it's there, you know how to answer it. What does the word disorganized mean? Disorganized is a mess, right? So it's a mess. So if the schizophrenia is disorganized, what does that tell you about the person? What should be the theme of the question? This is the patient that I'm going to look at them from across the street, and I'm going to know that they're schizophrenic, because how they talk, how they dress, how they act, how they behave is going to be so out there that I will know that it's a schizophrenic. So a 21-year-old, notice the age. What does that tell you about the prognosis? It's not good. 28-year-old man is taken to the hospital by his mother because of bizarre behavior at home. He's disheveled and is wearing many layers of clothes despite that it is summer. While in the waiting room, he appears to be childlike and he's barking. He admits to auditory hallucinations. His mother reports that he's been this way for years. So we know that we have a very sick kid. The moment that you're this sick, you immediately become disorganized. And this is the one that's the worst prognosis. The catatonic, the theme is going to be psychomotor. So something is going to be different regarding your psychomotor in these types of patients. Either you're moving a lot or you're not moving at all. So while working in a psych unit, you notice a 43-year-old woman who's been hospitalized for years due to mental illness. While on the ward, she remains mute, doesn't respond to questions, and while in group, she stares at the wall and stays in a fixed position until the group ends. So they're telling you that there is something abnormal with her psychomotor. So the moment that's there, you know that it is the catatonic type. So it's either a lot, so it's either slowness, severe slowness, where you're not moving at all, or severe excitation. Do all of you remember the Taz, the Tasmanian Devil, the cartoon? What would the Taz do when he would come into the room? Like, rah, and spin and destroy everything? That could be a type of catatonic. Also, the slowness is also, you could stay like that for hours and not move. That's what you see. What they've done with schizophrenia is that you see this catatonic, they've added it to everything. You could be depressed and catatonic. You could be schizophrenic and catatonic. So they've added a catatonic subtype to other disorders. And then we have the undifferentiated, which means I'm clueless, like fever of unknown origin, right? How do I know that's it? I rule everything else out. Same concept here. A psychiatry evaluates a 19-year-old man after he complains to his friends of hearing voices. When asked what the voices talk to him about, he's not sure. He says they're coming from his head, and he's got loose associations and derailment. So he doesn't say anything. It's not voices telling him that people are after him. It's not voices telling him that he's the king of Saturn. There's no psychomotor disturbances. He is psychotic, so that's what undifferentiated is. What's the one where they have the paranoia, they're functioning? I think it was something about a cab driver who believes he has a van, but he hasn't been a good worker and never hospitalized. That is not schizophrenia. That could be delusional disorder. The personality disorders, we're going to get to them. Okay. The schizoid personality is not paranoid. The schizoid is just a loner. That's all it is. And we're going to go over, once I finish this and then I bring in the personalities, we're going to go and review everything together again. All right, so the undifferentiated, you just don't meet criteria for the others. The residual, what's the word residual? Residual is what's left over, right? So I'm drinking something here. I've got a little bit left over, so that might be my residual. So how does that translate into a diagnosis? Well, I know you're schizophrenic. The symptoms of schizophrenia, a lot of them have gone, but something is still left over. And what's left are the negative symptoms. That's what residual schizophrenia is all about. So a 50-year-old homeless man is taken to the hospital after he was hit by a car. Staff who question him note that his thoughts are illogical. He's got poor grooming, emotional blunting. What are those? Those are negative symptoms. Where is it there that he has hallucinations or delusions? Do you see it anywhere? Nowhere. So that's what residual is. They're usually older and they don't have positive symptoms. And it's not because they're taking medications. They're not on medications and they don't have positive symptoms. All right, so are we clear with those 5? But remember, those 5 don't exist anymore. So I cannot imagine that they would appear on the exam because those diagnoses do not exist anymore. So what they'll probably do is just give you the diagnosis, schizophrenia. So as far as you are concerned, your diagnoses just got easier. Because before what they would do is they would give you schizophrenia paranoid type, schizophrenia disorganized type, and you really had to fine-tune your knowledge as to what was what. Now, forget about it. It's schizophrenia, simple. So the questions will not be as difficult for some of you. Now, why did they remove all that? Because they found out that people really struggled with it, and it really made no difference what type of schizophrenia you had. You either had it or you didn't. So because of that, they said, get rid of it. Now, let's go over time, because time, you know, sometimes when I look back at the things that I've drawn, I always wonder, what do people think if they come into a room after I've left and they see all my crazy drawings on the board? They're like, wow, what is going on with this person? All right. So time is going to be important for some things. If you have symptoms for more than 1 day, but less than 1 month, versus symptoms for more than 1 month, but less than 6 months, or symptoms more than 6 months. Each one of these things is going to be called a different disorder. We already know that for you to have schizophrenia for more than 6 months, right? Schizophreniform is when you have the symptoms more than 1 month, but less than 6 months. And brief psychotic disorder is when you have more than 1 day and less than 1 month. So how does this work out? Typically, the people who have brief psychotic disorder, typically maybe something happened to them here. Doesn't have to have, but probably something happened. And as a result of that, you develop psychotic symptoms. I give you medications, I give you antipsychotics, and chances are you will return back to what's considered normal. People who have schizophreniform will probably also return back to normal. However, the people who have schizophrenia, it's very hard for them. So this is like a big wall. It's very hard for them to return back to normal. So once you pass this line, it's hard to get out. So once you have that schizophrenia, that's it. There's no turning back. And it's harder for you to return to what's called your pre-morbid level of functioning. So the person who had brief psychotic disorder, 15 years from now, they can have another episode. The person who had schizophreniform, 4 years from now, they can have another episode. But the person who has schizophrenia immediately stays with the diagnosis of schizophrenia, and you will have the disorder for the rest of your life. Does that make sense for everybody? All right, good. So what is important for you on the exam, for you to have the diagnosis of schizophrenia, I don't want you to worry about time. I don't want you to look at a question and say, oh my God, there's no time on there. It cannot be schizophrenia, because it can. Look at the symptoms. Time is important in brief psychotic and schizophreniform, because how do you differentiate brief psychotic from schizophrenic? Duration of symptoms. How do you differentiate schizophrenia from schizophrenic? Duration of symptoms. So for brief psychotic and schizophreniform to be correct, look for time. If it's not there, do not give it as an answer. Okay? Does that make sense to everybody? Time is crucial in how we make these diagnoses. Are schizophrenia and schizophrenia, are they different? They can be a continuum. They can be. They don't have to be. So you can have a person who develops symptoms here. 1 month goes by. They're now called schizophreniform. 7 months go by, and now they're called schizophrenics. Or you can have a person who develops symptoms. 2 months later, their symptoms are done. And that would be schizophreniform. So it can either be on the continuum or doesn't have to be on the continuum. And all three of them get antipsychotic medications, correct. All right, so let's go back to the diagnoses. Let's go back to the slides. Can we treat schizophreniform and prevent them from developing schizophrenia? You know, I think that if you're going to get it, you're going to get it. And if it's in your genes to get it, it's going to happen. So I don't think you can necessarily prevent it. So let me get some color here. Hold on. Let's use a different color. I always use pink. Let's use... Oh, so much for choices. Here, let's use orange. A 35, when they go back to normal, can they stop meds? Yes. Red, you want red? Let's see. It's hard to see what red is. I mean, I think this might be red. Oh, wait, this is like brick red. There we go. A 35-year-old Chinese immigrant is brought in by neighbors. Let me make it thicker. Hold on. After she was found wandering in the streets yelling out someone's name. She appears disheveled. Remember, clue? She's disorganized. She arrived in the U.S. several days ago and upon her arrival witnessed the death of her 3-year-old son. While in the waiting room, she's responding to internal stimuli. When you see that, it means that they have auditory hallucinations. So they're listening to voices. So what is this diagnosis? It's brief psychotic disorder. Why? Because we know that it's more than one day, but less than 30 days. So these individuals can have hallucinations, delusions, disorganized speech, any kind of symptoms, but this is what's important. More than one day, but less than 30, and of course, you treat her with an antipsychotic. We are going out of order. Let me go to this one first, okay? Does it have to have an acute stressor? When DSM-3 became DSM-4, they removed the stressor part, so it doesn't have to have it, but it usually does, if that makes sense. Mrs. Jones is evaluated at a nearby clinic after she was acting inappropriately at work. According to her coworkers, she began acting strangely 3 months ago. She was wearing a hard hat to work, and when asked why, she replied, "I will not let you read my mind." She also believed that others were talking about her. She had to be escorted out of the room because she started to argue with others whom she believed were controlling her mind. So we have this theme of paranoia, but it's been going on for 3 months. So what do you think the diagnosis is? Because it's more than 1 month and less than 3 months, we know that it is schizophreniform disorder. And how do we treat antipsychotic medication? Does that make sense to everybody? Yes? Okay. Then we have schizoaffective disorder, which is a patient who has symptoms of schizophrenia as well as symptoms of a mood depression or bipolar. It doesn't matter. I would be very suspicious in picking schizoaffective as the correct diagnosis in the question. They tend not to be the correct answers. A 25-year-old woman is found walking nude in the shopping mall. When asked why, she replies, "I'm making it easy for others to have sex with me since I know they all want me." She states she heard a voice telling her she was irresistible and everyone wanted her. When she speaks, she cannot focus on one topic at a time and frequently jumps from one topic to another. Her mood is euphoric and her affect is labile. What's her diagnosis here? It sounds like bipolar disorder. She recounts an episode last year when she heard voices that she could not describe and believed others were following her. It's been for more than 6 months. So what do we have here? Schizophrenia. So what's the diagnosis? Schizoaffective disorder. All right. So I would be very careful. Yes, more than 50% of patients, when they have mania, can have hallucinations. So it's very common. So that is schizoaffective disorder. So let's review certain things, because you're getting a lot of questions here. Let me go to the whiteboard. I want you to think of, let me get something here. Think of things as if though it were a scale, okay? So we have a scale. Here, we're going to put the depressive symptoms. Here, we're going to put the psychotic symptoms. I don't think you have a problem differentiating schizophrenia from major depression. Is that correct? Those two are easy. I think the problem, major depression with psychosis versus schizoaffective disorder. Is that correct? That's where you probably would go, what's going on? All right, so look at the question and let's symptoms in our scale. For you to have major depression with psychosis, where the scale is going to be tipping towards. So let's review a case. The patient complains of depressed mood. Where do we put it? Here. She's not sleeping. Where do we put it? Here. She has no energy. Where do we put it? Here. She feels hopeless, helpless, guilty, worthless, doesn't enjoy life, and she's having auditory hallucinations telling her to kill herself. Where did the scale go? What's the diagnosis there? So which one of these would it be? Major depression with psychosis. This symptom is not enough for schizophrenia, is it? It's just one or two psychotic symptoms. That's major depression with psychosis. Now, let's go back to our scale. Let's put depression here. Let's put psychoses here. A patient who has depressed mood, helpless, hopeless, flat affect, poor grooming, hallucinations, loss of energy, thoughts of suicide, delusions that she's being followed. Is that major depression with psychoses, or is it schizoaffective disorder? Is it A or is it B? B. Okay? So the more the scale is equal, the more chances that it's schizoaffective. Does that make sense to everybody? Now, it's not as simple as I'm making it out to be, but for the purpose of the exam, this is what I want you to focus on. All right. So let's continue. Can I make another scale comparing BP1 and schizoaffective? Sure. Let's see. Bipolar 1 and schizoaffective, is that what you want? Bipolar 1, what type of bipolar 1 do you want? Remember, bipolar 1, they're going to give you just mood. Not sleeping, talking fast, increased libido, racing thoughts, delusions of grandeur. Is that bipolar disorder, or is that schizoaffective disorder? Is it A or is it B? That would be bipolar. If it were schizoaffective, then they would have to give you symptoms meeting schizophrenia. Does that make sense? All right. Let's go back to the slides. Then we have a disorder which is called delusional disorder. And what was a delusion? Because schizophrenia, remember, for you to be schizophrenic, how long do you have to have the symptoms? More than 6 months. All right. So Mr. Smith has been married for 10 years, and during most of those years, he believes his wife was trying to poison him to get his money. He frequently complains of stomach pains, which he believes are due to the poison in his food. His thoughts are logical and coherent. He's got no hallucinations. His wife, an independently wealthy woman, does not understand her husband's logic because she has more money than he does. So, is it possible for a woman to want to kill her husband for his money? What do you think? Yes. So, is this possible? It's unlikely, but it's possible. So, his delusion, we know that it's been going on for more than a month. That's what delusional disorder is all about. Okay? So they're usually non-bizarre delusions, 1 month, an intact level of functioning. And the way you treat it is with antipsychotic medications. So remember, how you differentiate a schizophrenic from a delusional disorder? Look at the content of the delusion and look at the level of functioning. Functioning people are delusional disorders. Schizophrenics are not functioning. Does that make sense to everybody? Yes? Okay. Let's review a few things. So we've got, I'm going to use the text box, so give me, be patient with me. So we've got 25-year-old man or male believes his wife is cheating on him. Is that A, paranoid personality disorder, or is it B, delusional disorder? Now, we haven't done the personality disorders, but I want to go over this. Actually, let me add a third in here. And C, schizophrenia, okay? So these are the 3 things, and we're looking at one basic thing where you believe that someone is cheating on you. What I'm going to do is that I'm going to give you clues of what has to be present in the question for you to figure out which one it is, okay? There's no right answer right now because I haven't given you enough information. The difference between the paranoid personality, so if we look at functioning alone, so if we're focusing on functioning, who tends to function? Those that function will be the paranoid personality disorder and the delusional disorder. Which one is not functioning? The schizophrenic. So if we're looking at functioning, then looking at the question might clue you one way or another. Another way to differentiate this is look at the delusion itself, okay? If the question mentions something about suspects, and the question meant something where I know that it's a fact, that's how you differentiate. The person who has the paranoid personality will say, you know what, I think my wife is cheating on me. I'm not sure, but I really suspect it. I haven't caught her, but I believe that it's happening. The delusional disorder will never use the word I suspect. They will use the word I know that this is happening. I don't need proof, but I know that it's happening. So it's different between think and is. Exactly. That's a good way of saying it. So that's what I want you to look in the question. So go back to the question. Does the patient believe it's a fact? Then you know it's delusion. If the patient is, I'm not sure, then you think it's paranoid. Okay? And schizophrenic, it's probably going to be, my wife is cheating on me with a space monkey. Okay? Then, well, yeah, you definitely are schizophrenic. Do you see the difference between these three things? All right. I think we are done with this chapter. Yep, that's it. So why don't we go on a break here, and I will see you in 10.